Okay, Dr. Maria, the scenario for you today is an 18-year-old lady. She has a BMI of 35 kg per meter square. She delivered 7 days ago. Pregnancy was uneventful, although delivery was also uneventful, but she had anemia throughout her pregnancy. Now, after 7 days post her delivery, she presented to you with an extreme pain down below at the site of episiotomy. So this is an let me repeat the scenario again. If you want to note down few points with yourself, you can note down. 18-year-old primey, para, BMI of 35 kg per meter square, uneventful pregnancy apart from anemia, which was present throughout the pregnancy, and her latest HB was around 9.8 in the last trimester. Okay, she had an episiotomy. Otherwise, the delivery was uneventful. Now she presented to you with an extreme pain down below at the site of an episiotomy. How you will proceed with this case?
And just a minute, ma'am.
Okay, you can take 2 minutes.
So,
Okay. So,
should I start?
yes, someone note down time for Dr. Maria, please.
I am Dr. Maria, one of the exam candidate. I've read the scenario. I'm ready for the structured discussion. As the scenario was given to me on 18 years old para one, her BMI was 35, delivered 7 days ago, and now she is presented with extreme pain at the episiotomy. So after mutual introduction and rapport building, I will confirm the details given in the scenario and inquire about her postpartum period. The duration of the pain, onset, how was the recovery after the delivery, and when was the delivery was conducted, and who was conducted the delivery, and where delivery was conducted,
Delivery was
and
conducted at a tertiary care hospital, and then she was okay, but 2 days back she started to have pain. Today it is worst. She's in extreme pain today.
okay. Is she on any? Is she took any medication for the episode? Is she able to void
Yeah,
urine
she
or
was
pass it
taking
through?
paracetamol.
Does she void after the delivery
Yes,
or
everything
any
is
symptoms
okay.
of urinary symptoms?
No, no urinary symptoms.
Uh, 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 then I will inquire any as as the history was given to me, she is anemic throughout her pregnancy and her BMI was raised. So I would also inquire about the antenatally any or intrapartum any difficulty during the delivery or postpartum she developed any PPH.
No, pregnancy was so postpartum. It was completely uneventful. She just had her episiotomy. But what specifically you want to ask? There was no postpartum hemorrhage.
Uh, what?
No, no, no postpartum hemorrhage.
Okay. And does she breastfeed her child,
Yes, she's breastfeeding regularly.
or does she care for the perineal hygiene, Or does someone who conducted the delivery in tertiary care hospital doctor told the postpartum pelvic floor muscle exercises are perineal hygiene?
Yes, she's regularly changing her pads and she's following the advice given by the midwife at the time of delivery for her hygiene.
Does she develop any fever or vaginal discharge, foul smelling
No,
along with the pain?
no.
Or does she any complaint of increased per vaginal bleeding?
No.
Uh, I would like to examine my patient.
Mm-hmm. Then what you will do?
On examination, yeah, I will check the general status of the patient. Is she comfortable in sitting position or not? Check her vitals and then do the perineal examination for the episiotomy for the cervicovaginal health.
Okay, so what you want specifically to look for?
For any as she complained tenderness, either there is any tenderness or episiotomy healing well or not, or the sutures taken or any perineal hematoma was
Okay, so
less likely, but could be
uh-huh.
there is.
There is a complete breakdown of all the layers of the episiotomy. Now, how you will proceed?
Uh, First, I will counsel my patient regarding uh, episode breakdown as in an empathetic way that it could be possible due to her raised BMI and due to her anemia. The healing was not good as she already said that she is changing the sanitary pads and perineal hygiene she is using. But due to the risk factors during her intrapartum and antenatal, her raised BMI and anemia could be the cause of breakdown of episiotomy.
Okay. Then,
Then I will admit my patient for the resuturing and perineal resuturing of the episiotomy if it could be uh, and I will start the antibiotics
mhm.
and analgesia. Once the patient symptom free, I will start with the red flag signs.
How you will do the repair?
Uh, First, uh, I will take the consent and in the shift the patient to OR and examine under anesthesia. For if only the episiotomy which is given, only that tear disrupted whole length, or there is increased lacerations or tear in the vagina. Then I will remove all the digestive tissues and repair the layer by layer with the interrupted sutures Vicryl 20 and again
Okay. So, what aftercare you will provide to your patient?
um, along with the antibiotics and analgesia, I will counsel my patient regarding the weight reduction, regarding the daily perineal hygiene, along with the regular changing of the sanitary pads, and sits baths 3 times daily in a warm water for 10 to 15 minutes. and correction of the anemia for the and high protein diet.
Okay, so what is the perineal wound dehiscence?
Disruption of the uh, mucosal or submucosal layer of the episiotomy.
What are the types of the wound dehiscence?
Uh, Three types.
Hmm. Okay. So what are the type? Can you name them?
Uh, First, if only the mucosa is separated, or the muscles are mucosa along with the skin, or the muscles, or there is a deep uh,
Mhm.
corridor.
Okay. So what are the immediate and long-term complication of wound dehiscence?
Immediate complication, she has this pain. Along with the due to this pain, she might be develop urinary and bowel symptoms of voiding difficulty
Hmm.
due to this pain. Uh, and there could be due to this pain, she might be immobile and increase the risk of thromboembolism.
Okay. What are the late complications? Okay. Do you want to add anything else to your presentation?
No, ma'am.
Okay. So at least I encourage you because you came forward and presented. Okay. If you have the confidence to present, the other things you can learn time to time because it's just about the knowledge. If you have the confidence, you can gather the knowledge and present it in a very good manner in the exam. Okay. So
Yes,
let
ma'am.
me tell you about this scenario. पहले तो एक बात जहन में बैठा लें, आपने हिस्ट्री टेम्पलेट कंप्लीट करना है चाहे वो आपके कोई भी पेशेंट हो. सो अरेंज योर सेल्फ इन सच अ मैनर दैट फ्रॉम द स्टार्ट, if you have differential diagnosis, but in this condition it was a clear cut that she is coming with pain, right? So she is
Yes.
coming with pain after, at the site of episiotomy. Still you have to take the history. Now you know about the diagnosis already. If it's a certain point when you don't know about the diagnosis, then your HOPI should comprise of the history points which excludes the differential diagnosis. But now here you already know there are some risk factors for the perineal wound dehiscence. Okay, I give you by purpose the 18-year-old lady with a high BMI and anemia during pregnancy. So these are some of the risk factors which are clearly pointing towards the risk factors for the perineal wound dehiscence. But now, how you will start your structure discussion, that I have read the scenario, I am ready for the structure discussion. My patient is an 18-year-old lady with a high BMI of 35 kg per meter square with anemia during her pregnancy. Now she delivered 7 days back, and now she's coming here with a perineal pain, that is pain at the episiotomy site. But before going towards the details of the management counseling of the patient, I like to ask some questions from my patient. First of all, I want to ask about, is she having any chronic conditions like diabetes, or was she on any immunosuppressive drugs? Okay. नाउ आई वांट टू आस्क अबाउट, अब पास मेडिकल के सारे एनीमिया तो उसमें है ठीक है, एनीमिया का उन्होंने बता दिया. नाउ आई वांट टू आस्क अबाउट whether she has been on any prolonged steroid therapy. Specifically, I want if she's asthmatic. Okay, how is her nutrition condition, like if she's malnourished or anything like that. Now she has given me the history about her antenatal period is given in the scenario, but I want to ask whether there was any prolonged rupture of membranes, was in an assisted vaginal delivery. If it was, then was it with antibiotic cover or no? So episiotomy. it was just an episiotomy or there was an obstetrical anal sphincter injury. Who sutured the episiotomy, as she asked, like if it was a poor surgical technique or a suboptimal hemostasis or it was under poor aseptic conditions, then it would lead to the dehiscence of the wound. Now, postpartum, I want to ask whether she had any fever, foul smelling discharge, how was her hygiene, as she asked. Um, is she taking anything to correct her anemia? Is she on any supplements? Okay, how is her general health? Once you have asked about all these things, then you should tell to your examiner. And I also want to ask about how is she feeling now at the moment, because this affects the mental state of the patient as well. She feel down and depressed. Specifically, I want to ask if it's easy for her to pass urine, is it's easy for her to pass the stool. Okay, and is this pain associated, sorry, is this
Okay.
pain associated with any abnormal discharge? Has she seen the wound? Is it open or not? Okay. Can she feel the suture
Sorry, ma'am.
material there or no? Whose mic is unmute? Okay. If any suture material, and is it affecting her quality of life? Okay. Once you have asked all these things, now you will tell your examiner. After that, I will like to assess the wound. So I want to check about the breakdown of the wound, assess the depth of the wound, and extend or check for any infection or check for any redundant suture material or any necrotic tissue. Once I have checked all these things, I will note down whether it is the complete breakdown of the wound, that is all the layers, that is mucosa, muscle, and the skin are involved, or it is only specific part or only the mucosa is open, or less than 50% of the wound is open in all the three layers. Why this is important? Because if it is less than 50% of the wound is involved and all the three layers are open, we call it partial dehiscence. But if all the layers are open and more than 50% of the wound is involved, we call it complete dehiscence. But if only certain, like it's up to mucosa or muscle and the skin is intact, still we call it the partial one, right? Along with the wound checking, I will check the surrounding tissue for any erythema, collection of blood or pus or any exudate or necrosis. Okay. At the moment when I'm examining my patient, I will take the wound swab also to send it for the culture and sensitivity. Now, I will look for the condition of my patient. If she is febrile or if I see any notice or if I notice any discharge at the site of the episiotomy, that is a pus or any exudate, I will start antibiotic empirically and not waiting for the culture and sensitivity report, but because it will take around 48 hours. So I will start a broad spectrum antibiotic. Okay, clear up till now? And
Yes.
I see any excess suture material, I will gently remove it. I will clean the wound and dry it. And as my patient is in severe pain, I will offer the NSAIDs. The NSAIDs I will offer per rectally because it is the more efficacious for the pain relief. Okay, after ruling out any allergy to my patient. Right, now I will check if the wound is wet, then I will go for alginate silver dressing. Okay, I will go for alginate dressing. The ultimate decision for the management of this patient, as my patient is having complete wound dehiscence, for these patients we cannot offer the conservative management. And previously it was a research or evidence based practice to go for the delayed repair of the wound, but now the evidence says that if you get the complete breakdown of the wound, you should not wait for it to be repaired by the secondary intention or the granulation tissue. You should go for the surgical repair after giving the antibiotics, and the antibiotics should be started 48 hours prior, 48 hours prior to the surgical procedure, right? So later on, once this scenario is complete, because it is going for the complete wound dehiscence, I will add more point for the partial wound dehiscence. Okay,
Oh,
so now I will go for the surgical management for this patient, but we will involve the multidisciplinary team in her management. If there is pus, we have to give the antibiotics, and there is the new recommendation is that we have to go for the repair. Okay, instead of waiting for the delayed repair, you give antibiotics, and then after 48 hours you can go for the repair, because the Because if within 48 hours it's the wound dehiscence occur, it means that it was a poor surgical technique. For that you have to go 100%, you have to go for the surgical repair. But apart from that, if you get a patient with a complete wound dehiscence, you can offer the conservative management you cannot offer, you have to go for the surgical repair. Okay. Traditionally, it was to wait for 2 to 3 months, but now the early repair within 2 weeks of the childbirth is associated with a shorter period of disability, decreased hospital stay and cost, and decreased psychological burden on the patient. And also, the overall success rate is 94%.
Ma'am, which MDT we will involve in this case?
Okay, so as your patient is, because it is a distressing condition for your patient, you can involve the senior obstetrician, right? The senior obstetrician, you can involve the psychologist to counsel this patient. Okay, you will not go directly for the repair yourself. You have to involve the senior, right? Okay, now let me tell you about the other things. So the surgical repair, it is performed under general anesthesia as a day case procedure because it will help the patient to return to home quickly, and the less risk of the urinary or voiding issues if we perform under general. The principles of the surgical repair is that you should give the IV antibiotics to your patient, the broad spectrum. The procedure should be performed under strict aseptic technique, and the examination should be performed under general anesthesia again to assess the extension of the wound dehiscence, including vaginal and rectal examination. Okay. Now you have to infiltrate the wound with the bupivacaine 20 ml or adrenaline 1 in 200,000. This will provide the reduced intraoperative blood loss and the postoperative analgesia as well. Viability of the perineal tissue should be assessed, right? You will tell, I will assess for the viability of the perineal tissue and do the surgical debridement, remove as the necrotic tissue as much as possible. Okay. And then I will repair the edges of the skin and vaginal mucosa in layers. Okay. The vaginal mucosa I will repair. Whose mic is on? The vaginal mucosa I will repair in the vaginal mucosa I will repair with continuous non-locking suture with vicryl rapid. And the perineal muscles I will stitch with the interrupted polyglectin vicryl 1. And the skin is closed with an interrupted vicryl rapid matrix suture, right? The wound is dressed with the paraffin gauze. And at the end of the repair, the vaginal and rectal examination should be done. And I will go for the rectal NSAIDs administered at the completion of the surgical repair. Post-operatively, I will ask my patient to take oral antibiotic for at least 7 days. Regular post-operative oral and rectal analgesia should be provided to the patient. And I will advise her regarding the perineal care and hygiene and follow up her in the perineal clinic or in the gynae clinic within 2 weeks to assess for the wound healing, right? Okay.
Okay.
And then I will discuss for the future deliveries, and I will give her the possibility of vaginal delivery.
Ma'am, what are the early and late complications which
Okay.
you asked from me?
Okay, the early complications, it could be like pain, okay, pain, bleeding. Bleeding could be there from the wound, right? The immediate complications are bleeding, the pain, the wound infection can occur, and the dehiscence can occur. But in long term, if you let these patients without any treatment, then she can have a pelvic floor dysfunction, chronic pain, urinary incontinence, fecal problems like incontinence, and prolapse and dyspareunia. Okay, and these things can affect her quality of life also. Any other question up till now? This is very important. And if they give the scenario of the partial wound dehiscence, then you can offer the patient the conservative management also by the secondary intention. And if there is over excessive growth of the granulation tissue, then you can cauterize it with silver nitrate. And if there is severe overgrowth of granulation tissue, then you can remove or excise it under local anesthesia. So this is how you will be telling. This is a very beautiful talk. It is, I think, May 2022 talk. It's the not that much recent, but it's a very beautiful talk.
Ma'am, please share this talk with us.
Okay, if you prepare from this one, then
Then what are the red flag signs?
red flag signs are simple. You will be telling to your patient if she is having severe pain that she cannot tolerate, if there is some difficulty in passing urine, if she is having fever. So if she feels that there is some discharge down below pus, or she feel again that there is disruption of the wound, then straight away come back to the hospital. Okay.
मैम ये लेयर वाइज क्लोजर का प्लीज दोबारा बता दें जरा, किस लेयर को किस में सूचर से रिपेयर करना है.
It is same as we do the episiotomy, right? You episiotomy we do with the vicryl rapid,
ओके ओके
right?
Ma'am,
मैम.
why we are not admitting this patient for the 24 hours?
Why you want to admit for 24 hours?
Because she came with extreme pain, and we are doing the surgical repair after 48 hours with the antibiotics. We will discharge with this pain.
So who
If
to?
she is
No,
unable
this
to
is what
void
I'm
our
saying. Now you will admit this patient, you have to give her antibiotic for 48 hours, so not for 24-hour admission, right? You are admitting this patient. You are not just admitting for 24 hours.
after repair, we will discharge this patient
Yes, after repair you can discharge.
on the okay.
But if the patient is stable, right? She's not having any fever, anything, and if after giving the painkiller you see her for some time, the pain settled, then you can call her again for some other day to go for this repair. Okay, but before repair, then you will admit her. But usually it is a, if the patient is settled, that she's having no fever, no pain, no red flag signs available, no red flag signs she's experiencing, then you can discharge her and call her back as a day case to do the, as we do usually in our day case
Oh,
setting. Okay. So let me repeat, the vaginal mucosa is repaired with continuous non-locking, rapidly absorbable polyglactin, that is the vicryl rapid 20. The perineal muscles are repaired with interrupted standard polyglactin vicryl 1, and the skin is closed with interrupted vicryl rapid in a matrix suture.